and so that he can get picked on too. So good morning, everybody. Thank you for joining us for our CAS conference. And it's a real pleasure to have a good friend, John Forrest, who's pretty close by up at Yale, who's the director of the interventional program, the structural heart program. And we've done quite a few things together, been on a number of conferences, and I've always learned from you, John. And I think your topic is one not just for for structural people, but I think for all interventional cardiologists now. More and more, we're going to have to deal with patients who've had a TAVR valve or who have AS and are going to undergo TAVR. So we're looking forward to hearing your tips and tricks.
Azim, thank you very much for the invitation. It's great to see you, even if it's over a webcam, and great to see your fellows there and everyone else who has joined. You know, I couldn't agree more with you. I think this is really a topic that is not a structural topic. This is a topic that is an interventional topic. And, you know, you'll see that through here. There are some little sort of details in here that I think structural folks will want to know, but really the vast majority of it, I think, is things that we really need to start as a whole interventional society having a better understanding of, talking about, and also educating each other about. So here are my disclosures. So really what I'd like to do is discuss the role of PCI prior to transcatheter aortic valve, review some of the risks for coronary obstruction that occur during TAVR, take a look at sort of how some tips and tricks of how to engage coronaries after TAVRs have been done, and then talk a little bit about valve and valve, because I do think that's a special area where there are some concerns. And so, you know, maybe I'll open this up here, and, you know, so what do you guys think the prevalence is of patients of coronary disease in patients undergoing TAVR? And Shun, I'll pick on you, because trust me, you're not going to be able to give a wrong answer. So give me a number.
Number, I don't want to say like a certain number, but it's majority is what I'm thinking.
Yeah, so it really depends where we look. Okay, so if we look in the first partner data, so this is partner high risk, where we randomized them to surgery or TAVR. You know, the percentage of patients who had coronary artery disease, about 75%. Okay. Conversely, if we look at this is the low risk Evolute paper. So if we look at the low risk Evolute paper, percentage of patients who have coronary artery disease here, about 15%. So it really depends a lot on our patient population. Certainly very high. We were used to very, very high numbers, you know, well over 50%. Now maybe it's a little bit lower, but I think it's important to note here that doesn't mean that these patients aren't going to develop coronary disease. We're just dealing with a younger, lower risk patient population. And we do know that there's a lot of concomitants between aortic valve disease and coronary artery disease. The two often go hand in hand, and it's something that we have to deal with. And so I want to start just by going over 4 cases that we've had recently here at Yale. Where we had to decide, do we PCI this patient? Do we proceed with a TAVR? Do we do neither? Do we do something else? So the first was a 78-year-old male with severe AS, progressive heart failure and angina, had a prior CABG, had a patent lemma to the LAD, a patent vein graft to a diag, and a very large caliber RCA filling via left to right collaterals. The cath was unchanged from where he had been 4 years prior. The second was a 72-year-old female on dialysis with distal left main disease, prox LAD disease, mid RCA disease, an EF of 30%, severe AS, and a prior lobectomy for lung cancer. The third was a gentleman with an 80% distal left main, as well as a 90% ostial RCA. And the fourth is an unfortunate patient with an 80% proximal LAD, metastatic prostate cancer, chronic renal insufficiency, who came in with an aspiration pneumonia and dehydration. And so I think the first thing is, are there some guidelines that can help us in looking at these patients? And so here are the guidelines for PCI prior to, or aortic or coronary disease prior to TAVR. And there they are right there. So that's what you have to help you out when we're talking about coronary disease before TAVR as it relates to guidelines that are out there. That being said, we have some evidence, and we also do have some guidelines, not for TAVR, but actually for surgical aortic valve replacement. And I think it's helpful to understand what are the guidelines for coronary disease before surgical aortic valve replacement, and also, what's the evidence behind it. So if we look at coronary evaluation prior to valve surgery, we'll see that unless it's emergent or it's a patient who's young, low risk, and a low likelihood of coronary disease, that the majority of the patients undergo a coronary angiography, and that if you have a greater than 70% diameter stenosis of a major coronary artery, or a 50% diameter of the left main, then the recommendation is for valve surgery with CABG. It should be noted that this is level of evidence C. It's a 2A recommendation. And in fact, even in these guidelines, these are the ones that came out in 2014 for valvular heart disease. When it was updated in 2018, they didn't update this part of it. So maybe on the next one it will be. But even there, they clearly state that there are no randomized trials that support the use of coronary revascularizations in all patients with asymptomatic coronary disease undergoing an operation. So, we don't have a ton of data, and that's just the truth of the matter. What we do know from some early study is that complete revascularization is certainly not a prerequisite for success when in patients undergoing TAVR. So this is some work that was done early on by our colleague Nick Van Meegen. And really what he looked at was patients who had in the red line either incomplete revascularization or in the blue line complete revascularization. And then in boxes C and D here, it was either sort of incomplete before the TAVR and incomplete after, incomplete before and you completing it after. And what he really found is there's not a major difference here, whether there was complete or incomplete, or even if you left coronary disease behind. I will note, if you look at D, what you see is you move out further months, that there does appear to be some relationship to the syntax score. So patients having more coronary artery disease and a higher syntax score probably aren't doing as well later on there. So, I think it's an important thing to note there. And I think Nick's made a very nice conclusion in his paper when he said it may be safe to waive variable degrees of coronary disease without intervention, and pursuit of complete revascularization is not a prerequisite for medium-term clinical success in an elderly aortic stenosis patient population, provided, and I think this is very important here, a rational and pragmatic approach to coronary disease by the dedicated heart team. And so let's go back here, and there are no right or wrong answers here. And so maybe I'll pick on Sharon. So our first case here, Sharon, the 78-year-old male, severe AS, progressive heart failure and angina, prior CABG, has a patent vein graft, patent lima, other ones is occluded, the RCA, having some angina, cath unchanged from 4 years before. What are your thoughts?
Well, I think this case is pretty straightforward. I mean, he has unchanged angiography, and angina may be related to the severe aortic stenosis. I would go to fix the valve. I mean, to change the valve and see what happens.
So I agree with you, right? That's what we did. I don't know if I think it's probably the right decision. People could argue, he's had some chronic angina, and is that from his, this large RCA that's filling via collaterals? But I think in this case, certainly TAVR alone as the first option makes sense. How about maybe I'll pick Manaf at the bottom of the screen if you're has severe distal left main disease, mid-RCA lesion, EF of 30%, has had a prior lobectomy for lung cancer, and has some heart failure.
I'm a little more concerned about the TAVR procedure in this patient because of her depressed EF and the distal left main disease, obviously. So I would strongly consider PCI prior to TAVR in this patient.
And how about that PCI? You're going to do a PCI with support? Any thoughts about doing other procedures along with your PCI?
I think having Impella support would be a great idea in this case.
So, I can tell you how we treated this patient, and this is how we've sort of gone to doing these patients. But often in these patients, what we'll do is we'll do a balloon aortic valvuloplasty up front. So you have a large sheath that's in place. Through that sheath after the BAV, we'll then put in our support device, be it a balloon pump or an Impella, and then we'll proceed with the complex percutaneous coronary intervention in that case. So I think, Manaf, you're right on there, right? So I think, the one thing I would add is I think a balloon valvuloplasty up front gives you a little bit of help there, especially when you're dealing with left main disease. And, you're going to put in a large sheath anyways for that, which you then can just use for your hemodynamic support. And this is a patient who we did about 2 weeks ago. I'm seeing her in clinic in 2 weeks, and assuming she's doing well, we'll probably schedule her for her valve thereafter. I've gotten reports over the phone that she's doing well. So I think exactly right there.
Yeah, I think, a little bit, John, people underestimate the value of doing a BAV. And it doesn't have to be an aggressive BAV, just a small balloon. It gives you a lot of wiggle room and makes the procedure just a little bit safer. And the patients tolerate, more complex PCI in a better way.
I couldn't agree more. I think, it's important to make sure this patient doesn't already have, moderate or moderate to severe aortic insufficiency, but assuming that's not the case, I think, a BAV up front, we found just really, really helps. You'll get, a 20-point rise in your systolic pressure almost immediately afterwards in these patients who have the really bad aortic stenosis. And it gives you that extra wiggle room, especially when you're doing left main work.
Yeah.
Shun, how about our third case here? 76-year-old male, 80% distal left main, 90% osteal RCA, normal EF.
So I think it depends on what kind of 76-year-old person this is, but you have a distal left main. Probably syntax score will be not as high. It's not like a high syntax score, but you could always have the heart team discussion. Either have a whole TAVR plus bypass option versus doing PCI up front, fix the coronaries first, and then TAVR as a second stage.
Yeah, I think you're right on. You want to talk to the patient, see what their thoughts are. Really have this. I think this is one of those cases where, a true shared decision-making with the patient is really important. That's what we did in this case, and the patient opted for CABG and surgical aortic valve replacement. Still certainly is plenty of times where I think that's the appropriate thing. And I'll take the last one here as we move on. So this is our 82-year-old with metastatic prostate cancer, renal insufficiency, and comes in with a pneumonia and dehydration. And we see a lot of these. I think we see more than we realize. And I really think it's important, especially in this day and age, that we still recognize that palliative care is an important option here. If this is somebody who was struggling super much with heart failure and massive volume overload, then maybe you could consider a pure palliative valvuloplasty just for comfort. But I don't think this is somebody who you should be putting through a complex PCI or somebody who should be undergoing a transcatheter valve. And I think, as a group of structural interventionalists and even interventional cardiologists, we need to recognize when there are patients who fit into this category and not do things just because we can do it. Certainly we could do that PCI, and maybe, it would be a nice, fairly straightforward PCI and other stuff, but there's really no need to do it. You're not helping that patient who has those problems. So I want to move on and move from sort of pre-TAVR, what do we do, into the TAVRs themselves, and what do we do there with regards to coronary disease. So this is a slide that our fellows make for all of our transcatheter aortic valve patients, and they then post it really on the lead shielding that's there, so we have it during our entire procedure. And so you can see here, this is a 79-year-old woman. You can see that traditional pear shape that she has here pretty impressively. BMI is 43. She has AFib. She has some lung disease. She's on oxygen. She has a normal EF, severe aortic stenosis. You can appreciate a lot of peripheral vascular disease here. She has a fair amount of coronary artery disease, a circ that's occluded, a large ramus, and her LAD and left main are okay. And our plan in her was we were going to leave that coronary disease behind. The circumflex was relatively small. It was primarily heart failure that she had. She was deemed high risk, and our plan was for a subclavian access. We've done a couple of percutaneous subclavians, although we tend to still cut down for our subclavians. And you can see our plan there with a TEE, a 23 millimeter sapien valve. So let's take a look a little bit more as we're doing her case planning. So here are some shots of her sinus of Valsalva. So you can see it there, measuring 25, 25, and about 27. You can see the height of her left main here, about 12 millimeters. Here you can appreciate at the level of her annulus, has an area of 350 and a perimeter of about 67, little over 67. And so when we look at the top of the screen here, we have our sapien sizing chart. At the bottom of the screen here, we have our evolute sizing chart. And so this patient fits in for either a 23 millimeter sapien valve or a 26 millimeter evolute valve. In this case, we decided to go with a 23 millimeter sapien valve. For the fellows there, we probably use just about 50-50 of each. We do each year over 150 evolutes and over 150 sapiens. And so we have a lot of experience with both of them. And so here's the procedure here. You can see your setup, seeing the nice 3 cusps. Our coronary heights were a little bit low, so we wanted the valve to be slightly deeper maybe than normal, maybe aiming for more sort of a 70-30, 75-25 implant. So you can see the valve deployment there. And then you can see our root shot afterwards. You can appreciate nice flow down the coronaries, no paravalvular leak. You can see the cut down that we've done to the subclavian artery there. And so the patient did great right afterwards. We took out the sheath. We gave protamine. We were excited. Everything looked really good. A nice, smooth, easy procedure. And about 20 minutes after the procedure, the patient developed hypotension. So maybe I'll go back to Sharon here. So 20 minutes after the procedure, your patient develops hypotension. A couple things on your differential.
Well, a patient after an invasive procedure, I would search for a bleeding. I would search for a pericardial effusion. I would search for the valve, for the dysfunction of the valve. I don't know, an embolization of the valve. And mainly this. I mean, once I rule out those etiologies, drug effect,
So I think you're on to all of them. I think you've hit them all. I like the way you got the first 3 right, as if we'd worked together planning this out. I always think you can't forget the last one. I know you don't want to say things about your anesthesia resident colleagues, but you never know who's there and what they've given. So we've laid out all of these possible problems. What's the first thing you're going to do? What's going to allow you the next step to help you sort of figure this out?
An echo?
Yeah, exactly. So never underestimate the use of an echo. I know that we've gotten away from transesophageal echoes, and I think that's a good thing. We often don't use as much transthoracic, but I do think it's a mistake to be doing a TAVR and not have an echo in that room to be able to do it instantly. So totally agree. So next step's an echo. And so here's this patient's echo, right? And so immediately we can see, this patient had a normal EF before, right? There's no pericardial effusion, right? The RV's not massively blown up, but it certainly looks here like our anterior wall is not moving very well, right? I think, this is, we happen to have a TE here. They put the TE probe quickly back down and immediately told us something's wrong with your anterior wall. Your anterior wall's not moving. And so, that led us down a specific path, thinking, if the anterior wall's not moving, the valve's in place, this probably isn't protamine. It hasn't responded. Something may be wrong with the coronary arteries. And so we quickly went up with a guiding catheter. And you can see here right at the ostium of that left main that there's really just a little pinhole right there at the ostium of that left main with a leaflet that's been pushed up against it. this can happen from time to time. We knew these coronaries were a little bit lower. You can see the subtotal occlusion of the circumflex artery here. You can see some disease in this ramus branch, but really what you're looking at here is the fact that there's just a little tiny pinhole here right at the beginning of the left main. And so we were able to.
John, I'm gonna challenge you a little bit, because on our CAS conference we also have Dr. Taub, who's the head of echocardiography, who wanted to just comment for the fellows, and I think it's important that on the picture you showed that was not the anterior wall on it. So I'm sure you saw it in another picture. So she made sure I want to make sure I got her comment into. She always catches me out whenever I say anything on echo. So don't feel bad. Welcome to my world.
No, you're right. That's why they keep us honest.
And they keep us honest, absolutely, because as interventionists, we often will jump the gun about what we say. Thanks, Cynthia.
So let's talk a little bit about coronary obstruction and transcatheter aortic valve replacement. So a lot has been written about it, and you can go through. There have been some nice reviews and other thing, and I've made a sort of just a little slide here that I think tries to summarize it up some. So the first, when we talk about the incidence and patient characteristics, so it tends to occur very rarely for native aortic valve disease, much higher for valve and valve. Interestingly, about 80% of the time it occurs in women, and it has a very high 30-day mortality rate, about 40%. It almost always occurs due to the native leaflet obstructing the ostium of the coronary artery. So that when we're talking about acute obstruction here. About 50% of them are partial occlusions, like we see here, and the other 50% are complete occlusions. And interestingly, it tends to involve the left main more than the right coronary artery. Some characteristics when we look at different data that's come out tends to be associated in patients who have a small sinus of Valsalva diameter and patients who have a low coronary height. And interestingly, when we look at the valve characteristics, it tends to occur more with balloon expandable sapien valves than with core valves. It occurs more frequently with smaller valve sizes, and certainly a significantly increased, about 5-fold higher increase when doing a valve-in-valve procedure. So some of these I think can be a little bit misleading. So let's just talk about this. So why would a self-expanding valve protect you as opposed to a balloon expanding valve? Do you think this is, I'll go back to Sharon here since he's a structural fellow. You think it's real or not real here? You think it's something about a balloon expandable that's more risky?
I think the fact that balloon expandable the balloon pushes and crushes the annulus and like moves all the calcium around might influence this issue of coronary obstruction.
Yeah, I think certainly is possible. Although I suspect it's not the case. I suspect in both you're sort of it's due to the fact it's a leaflet, you're pushing the leaflets out to the sides. There's one big difference when you look at the sizing charts for an evolute and when you look at the sizing charts for a sapien. Can you appreciate what that is there? And what it is that for an evolute, you have a sinus of Valsalva mean diameter that you need to meet. Okay. And in fact, if you don't meet this, you would be doing an off-label procedure, a procedure that's going to be too risky. And so if we look at our patient here, right, for a 26 millimeter evolute, he needs to have a sinus of Valsalva diameter that's greater than 27. Clearly, he doesn't meet that. And so what I suspect is the reason for this is that you see a sizing chart like this, you say, I can't use an evolute because I have a small sinus of Valsalva diameter. You use a sapien valve instead. And it's important to note that size of your sinus of Valsalva is one of the largest predictors for the risk of coronary obstruction. And so just because it's not listed there with your sapien sizing thing, don't think it's not important here. And I think certainly in this case, that small, almost stovepipe aorta was a key thing there. And Azim, I'll throw it out to you. I personally I find it hard to say that, there's something about a balloon expandable valve that's going to give you a higher incidence of coronary obstruction when you're really just displacing the leaflets. But maybe it's more than that. This is my theory on why we see this, almost 2 to 3-fold increase when we just look at the pure numbers of it. It's really because we're protected against it because of, the guidelines for the implant.
Yeah, I completely agree. I think for acute obstruction, I really don't think there's a real difference between the two. It's got to do more with sizing. For delayed coronary obstruction, I'm not so sure. I mean, there may be some difference there between the two valves.
No, I think it's a very fair point. I think it's it's a good thing why you need to understand. I think for the fellows and others on here, when you get data like this and you see something like this, you say, "Wow, look at this! There's a p-value that's been put on this. There must be a statistic. There must be a difference here." But you have to look really what's going into that. What's going into that? What are the confounding effects that are there? And so, I think this is one of those nice examples.
Yeah.
So coronary obstruction and TAVR management. So first, I think wherever you're doing your TAVRs, you need to have PCI equipment easily accessible. Second, you probably want to have some sort of cardiopulmonary backup, whether it's an Impella or an ECMO or something where you can really help out your patient there. In high-risk cases, especially patients who have a combination of low coronaries and a small sinus of Valsalva, often I'd recommend considering prophylactic coronary protection with a guide wire and even possibly a stent that's in there. There's been a lot of, people have different ways of doing this. Some people will do an angiogram with the balloon inflated to see if there's flow down there. I think that's one nice way of doing it. When you're doing that, a couple of things that I would point out. One, you need to make sure that your balloon's not occlusive at the level of the sinotubular junction. Otherwise, you're going to block it there anyways. You want to make sure that flow comes down and you're looking at the coronary leaflets that could potentially obstruct it. And the other thing is, I don't think it does a really good job of predicting that incomplete obstruction. So, we've tended to steer away from it a little bit, although I will say we still consider doing it, because if you do, I think if you get coronary obstruction with the balloon inflated, and as long as you're below the STJ, then you probably are saying, I need to do something here. But I wouldn't rest your laurels on the fact that since you still had flow down the coronaries at that time, that you're going to be fine with your PCI or with your TAVR. In these cases where we're really worried about something, we have a low threshold to go to use a transesophageal echo. It gives us immediate feedback. We do it sort of similarly if we have massive bulky calcification and we're really concerned about how the valve's going to interact with the annulus, and we want to look at that calcium movement. So we still use TEE in a fair number of our cases. We talked a little about the role for angiography during balloon valvuloplasty. And I think it's important that this is one group of patients, especially if you're dealing with a low risk patient here, that if you have low coronaries and a small sinus of Valsalva, that's a concern for the patient undergoing the TAVR. I'll go back to that slide. I don't want you to think it's not a concern for patient undergoing, a native aortic valve with a surgical valve. There still is a risk of coronary obstruction, as you can see here with that. And it's actually an important thing, I think, if you know that's there, to make sure you've talked to your surgeons about. I had a case not too long ago, actually a fair while ago now, when I was early on, where we sent a patient to surgery because of low coronaries. I didn't do a good job communicating to my surgeon that the concern there was acute left main obstruction, and they had to go back on pump and bypass the left main. And so I think communicating that to your surgeons, not just where the coronary disease is or what the anatomy is like, but also where the heights of those coronaries are, is an important thing that you should be doing if there are concerns there. So going back to the patient here, what we found and what often happens is once the guide inserted better, we actually had improvement in our blood pressure. So we engaged it with the JL4 guide, had improvement in our blood pressure. We went ahead and stented the ostium of the left main there, and had very nice recovery of the LV function. Immediately afterwards, the patient went home on post-operative day 3. So, this is one where you were able to, because it was just a partial obstruction, really get a nice result. And you can appreciate now where we're taking this shot, it's wide open here versus that pinhole that was there previously. There certainly is some other coronary disease that's there that had been present from before that we left behind.
Next, a quick question regarding the prophylactic. Is a guide extension, not just guide wire and stent, but guide extension, or?
Yeah, so what we will often do is bring a guide extension down there with it. And the reason for that is that it can be difficult to manipulate the stent after you've deployed the valve. I will say, having seen a couple of cases where the stents have been sort of torn off, and also some cases where they've sort of, like this one here, where just with the guide, with the wire down and the guide there, there's been good flow. My inclination in these patients has been to go ahead and stent, even if I think the flow is going to be good there. I think the risks of that are a little bit lower than the risks of late obstruction. So it's rare in these cases for me that I do the procedure, have a stent down, and don't complete the stent. Azim, sort of your thoughts there? I'm not sure how often you'll pull the stent back out saying, I'm really confident we're not going to have a problem.
Yeah, I think it depends a little bit on which valve I'm implanting.
Yeah.
With the Edwards, if I'm worried about coronary obstruction, I'm always putting the stent in, because you can usually see the leaflet right there. What worries me more is with core valves, because often you have to really snorkel those stents up. And we've been doing that for a long time. The data doesn't look bad, but there've been some patients who've had sudden death and so on. So now what my approach has changed for core valve is that when I protect the coronary, and it's usually with valve in valves, and I release my valve and it flows good, through the valve sheath, I will then re-access the coronary another time, but going inside the valve.
Yeah.
Pull out my jailed guide catheter and guideline and so on. And now if I have to stent, I'm stenting into the valve rather than having my stent sitting behind the valve. Yep. So I'll do a lot more of that now. Takes a little bit more time, but I kind of always think about, if that patient ever has angina and one of my colleagues has to come back and cath that patient, and I put those stents behind the core valve, they're never going to get in.
Not getting back in. It's a great point, right? If you're snorkeling stuff up there, it's one of those ones where you're saying I know we're not re-accessing these coronaries. So I think you want to make sure that that's that really almost prohibitive surgical risk patient that you've decided to do that.
Absolutely.
Sorry, one more question. Sorry, before on that access site.
Yeah.
With more of a shockwave coming along, would you consider femoral with the BMI was really high on considerations too, but do you do more?
Yeah, I think shockwave has been a wonderful asset for TAVR, especially for facilitating the femoral approach. We've used it more and more. The success rate's been great. It hasn't been 100%. We had a case where I was almost certain we were going to be able to be successful with shockwave about a month and a half ago, where despite our best efforts and multiple uses, and we used up all of the pulses in the balloon, we still weren't able to pass the stuff up. And so we rebooked the patient and brought her back for an alternative access. But I would say, shockwave has really changed our threshold for trying a femoral approach, and the success has been quite high.
Yeah, similarly with us. We've almost abandoned all other access sites because of shockwave. We've had a lot of success. Just before we move on, there was a question from one of the other fellows joining, from Mohammed Al Amoudi, who asks, do you have any preference for your supportive wire while doing coronary protection? Number one. Number two, do you ever do kissing balloons with a valve to make sure you're not squashing the stent?
So to get to the first one, so I don't really have I take my standard, pro water or run through something like that. I don't use a jacketed wire that I might sort of, it's going to be scraping against the metal as you pull off. It's not really necessary to put it down there. So I use our standard wires there. And with regard, so often if we're going to do, if we have a really high concern that there's going to be coronary obstruction, what we will do is we'll do our valve, often with the sapien valve, not always. We'll then have that valve inflated, have the stents just a little bit distal to where we want them. We'll then pull the stents back so that they're just outside the ostium of the left main or right coronary artery, and then inflate the stents there. So we inflate the stents after we've inflated the valve. I don't think that the radial force of the stents, you need to worry about sort of crushing the valve itself. But if you did it in the other way, where you did the stents first and then the valve, certainly you could, the radial force of the valve could crush the stents there. So that's how we had to do it. We had a case not too long ago, you know, actually a fairly young patient, but dialysis, lots of other things, incredibly low coronary heights and small sinus of Valsalva, where we inflated the sapien valve, had, you know, multiple access sites, and stented both the ostium of the right and the ostium of the LA of the left main. The patient did quite well, but in that case, inflated the valve first, then did our stenting afterwards.
Yeah, absolutely. And then he asked another question, which is also interesting. It hasn't been an issue for me, at least in the last few years, but what kind of wire do you need to cross when you have some of these really acute coronary obstructions? I mean, personally, you know, in the case you had, for example, I'm sure you crossed with your workhorse wire, because I think there was still a lumen. I remember years ago, we completely closed the coronary with a leaflet, and we tried everything. I mean, we tried the back of the wire, confianza. We could see where the ostium was, and we could not get into it. Thank God that doesn't happen very often and anymore to the fellows, because I think most of us, you know, John included, we predict these cases beforehand. So we were early on in TAVR, we messed up and we had those cases because we were not good at predicting coronary obstruction. Now we're better, and, you know, and all the publications show that the patients who have the lowest mortality with coronary obstruction are the ones where you protected them. So if you think about it, protect them.
Yeah. So, you know, it's a great point. So, you know, sometimes you have to sort of wire offshore a little bit. And in those, I do find that sometimes a hydrophilic wire, take a pilot wire, a pilot 50, a pilot 200 can be a little bit of help, just because you have such fine control with it.
Right.
I think it's important for the fellows to recognize that when you have coronary obstruction, okay, and you're doing it, so the two ways you can have either it's a valve and valve, and it's the leaflets of the old surgical valve, or it's a native one, and it's the native valve you've pushed off there. If it's the native valve that you've pushed off and occluded the left main, that is a heavily calcified thick valve. It is almost impossible to poke through that valve. There may have been some cases somewhere, I haven't seen them personally. I have seen a couple of cases of where there's been a failed bioprosthetic valve for AI or for other things, where they've pinned that up. And then they've been able to take, you know, a confianza or something else and poke through that valve of the surgical valve that's there, or the transcatheter valve that's there. But two very different valves, right? One's been in the patient for 80 years, is thick, is heavily calcified, and the other you're poking through some pericardium of a bioprosthetic valve. So when you sort of hear stories about that, understand which of the two it was. If it's the native one, it's going to be, I mean, maybe you can do it, but it's probably going to be almost impossible to poke through that thing.
Yeah, absolutely. And then maybe the one other thing I would just add to that, because I remember it happened to us once in Milan. Antonio calls me into the room because he has a coronary obstruction after a core valve, and he's trying every single catheter to cannulate. He can't cannulate, and he's now about to call the surgeon for bypass, right? To take the patient with urgent bypass. So you do have one other option with a core valve, right? You embolize the valve.
Yep.
So if you have a coronary obstruction, the quickest thing to do is grab it with a snare and embolize it, and the patient's alive, right? And then you have the time to think about what are you going to do next. But you can very quickly save a patient by embolizing the valve, and it will save them much quicker than trying to get them to have an urgent bypass.
You know, I will say, you know, similarly, we've had some cases, or one case recently using Evolut, where we were worried about the coronaries. We deployed the valve so that it's, you know, fully functional, but you're still holding on to it. And the patient immediately tanked, dropped its pressure and everything else. And you could see in that case that there was clear, you know, coronary obstruction. So I do think if you're using an Evolut valve and you're a little bit worried about it, pause at when the valve's fully functional there before you fully release it and take a look. That doesn't mean you're guaranteed after you release it not to have some further expansion. We know that that valve increases a little bit more when you fully release it. But, we had a case the other day that, was a perfect example. We were a little bit worried about it. We did it and the patient had clear, no flow down the left main. So we recaptured the valve. We tried implanting it a little bit deeper. The exact same thing happened. So we took it out and said, we're going to have to plan to do this differently. It's not going to work with our standard approach here.
So John, I'm going to share with you one more case because it was like one of the most dramatic cases I've had this year, right? One sitting next to me as well, one Granada. So we're doing a core valve evolute, right? Because I didn't want to do an Edwards because it was a 20. We going for fairly high implantation, and as I release the valve, it pops up. It clearly pops up, okay? And patient's fine. I do a aortogram, was actually, and I see that the valve, there's no leak, okay? But I don't notice something really important, okay? And what I don't notice, and I think Sharon should publish it, is that the neo-sinuses of the core valve are above the coronaries.
Yeah.
Okay, and so the patient's fine. The ECG doesn't change, but the patient now only has systolic flow of their coronaries. They don't have diastolic flow anymore because the left main is below the new leaflets. So every time the heart contracts, during systole, there's flow. The minute the leaflets close, no flow. So I don't notice it, huge mistake. I walk out of the room, 20 minutes later, she's arresting on the table, okay? And I have to put her on ECMO. And the quickest thing to solve it was I grabbed the valve with a snare and I embolized it and she came back immediately.
Yeah.
I put another valve through and I could decannulate on the table. So it's just something to watch because it's not a commonly described mechanism of coronary obstruction, is the fact that if you're too high, you actually can have only systolic flow to the coronaries.
Yeah. No, it's a great point. It's a great point. So let's talk a little bit about coronary access after TAVR. So, within the literature, the rates are quite high, and the clinical data shows that your PCI success rates, tend to be greater than 90%. That being said, reaccessing the coronary arteries after TAVR, especially when the frame of the TAVR extends above the coronary ostia, is often not easy. And selective engagement may not always be possible. So this is a recent study. Actually, I'm not sure if it's out yet or if it's just it's e-published right now, but this was the reaccess study that recently came out, a really interesting study. And so what they did is they took 300 patients, and when they were at the time of the TAVR, they engaged the coronaries, they did the TAVR, and then they engaged the coronaries afterwards. Of the 300 patients, about 123 were undergoing evolute, 96 were undergoing S3 or S3 Ultra, 72 accurate neo, and a handful of portico valves. And here's what they found. They found that beforehand, there was no problems engaging the coronaries. Afterwards, certainly it was more difficult. So for the left coronary, you still could selectively cannulate it in over 80%. But in 12%, it needed to be semi-selective, and in about 4 to 5%, it was unsuccessful. In the rights, the rate of unsuccessful was higher, although the rate of semi-selective was, the rate of unsuccessful was the same, but the rate of semi-selective was significantly higher. And I think it's important to note here that of the 23 cases where they could not access the coronaries, 22 of those were in evolute valves. Now, again, just like we were talking before, this needs to be taken with a grain of salt, right? You're not going to spend a tremendous amount of time, use huge loads of contrast to try to get into these arteries like you would in a patient who's having an acute MI and you're trying to do anything you can to get in there. But I think it does speak to the fact that, with the evolute valve coming above the sinuses, you're going to have more difficulty engaging it. And interestingly, the right is often going to be more difficult than the left to engage. And that was shown here nicely. So one of the reasons for that, and so pretend you're the left main artery. So everyone who's sitting at their screen is the ostium of the left main, and you're looking at now out at the valve that's been implanted. So if your heart valve is anatomically aligned with your coronary ostium, then you're looking out and you're seeing this nadir of the leaflet that's there, and you're probably open to the rest of the body. However, if the commissural post is not anatomically aligned at you, when you're the left main and you're looking out, you're seeing this commissure here. And it's quite likely that this commissure is sitting in front of you. So it's not going to be obstructing you because there's still a sinus of Valsalva, right? So it's further away from you, but it's obstructing such that if you went straight out, you wouldn't go out through frame, you'd go out and you'd hit that commissure right there. And so this is one of the reasons why, engaging with the evolute can be difficult. For the sake of time, I'm not going to go into a lot of details here, but I will say that for those of you who want to read more about commissural alignment and other things, Gilbert Tang has written extensively on it, has some really nice papers about how to align it up, how going in with your flush port at 3 o'clock can be helpful. And so I'd encourage folks to go out and read some of Gilbert's papers that go into some really nice detail about that. So in the past 2 weeks at Yale, we've actually had 3 cases where we've had to engage through valves. We had a patient, 2 of them were STEMIs actually. We haven't had STEMIs in a long time in valve patients, but one was 7 days out, a patient who came back with HIT, had a PE and also had a coronary thrombus. One was 3.5 years out, a patient who had an RCA, and one was an elective PCI for a patient who had developed progressive angina. As it so happened to be, all of these patients had an Evolute R or an Evolute Pro valve. And I think there are some tips and tricks to engaging in Evolute valves. And so this is something that I think all interventional cardiologists are going to really need to understand, not just structural docs. So I want to go through a handful of these tips and tricks for folks. And really there are 5 of them that I'm going to go over here. The first is that when you're accessing, whether it's for a guide or for diagnostics, I tend to use a JL and a JR catheter. I don't use XBs. I don't use other sort of supports, AL1s, AR2s. I tend to use JLs and JRs. Now, does that mean that they're always going to work? No, but those are my go-to catheters for this. Whereas usually when I'm doing LAD or left main work, I'll tend to use an XB. I won't do that for these. It's been shown, and I think when you do the models, that really the frame of the valve allows for these standard shaped catheters better than the shape of other catheters. The second is that it's beneficial to downsize the guide catheter by about 0.5 centimeters. So if you usually use a JL4, try a JL35 or a JL3, and you may have better success there. Similarly, for the right, if you usually use a JR4, try a JR35 or JR3, and you may find more success with that. I found that it just gives a little bit more maneuverability through the frames and more flexibility to reach the coronary ostia. The third thing is that what you want to really do when you're engaging these catheters is get your catheter at the height of the coronary artery and manipulate it from there. Clock the catheter, counter the catheter from there. You don't want to try to engage from below or really try to engage from above. So similar, we're used when we're engaging the right coronary artery to put it down into the right cusp, to clock it and to pull up. And that tends not to work here. I'd put yourself at the level of the coronary artery and try to clock it in from there. That's how I found it's really the easiest way to do it. You're trying to go through through the frame here, and you can see that there. The frame is fairly large, right? It can take a 10 French catheter if needed, but recognize that if one of these frames happens to be in there in front of the valve, it's going to be a little bit more difficult. Certainly not nearly as difficult as if you have a commissure like you see right here that's in front of the coronary ostium. If the engagement's unsuccessful, you can consider changing the size of the catheter, targeting an adjacent frame, attempting partial selection. And that's often what we have to do here, is that you end up getting your catheter, down here on the left or down here on the right. You're able to see where the ostium is, but then you really have to, what I call wiring it from a little bit offshore and then getting your catheter to set in better. And often using a guide extension catheter can be helpful there. Again, use guide extensions liberally. I find they're quite helpful in these cases. Sometimes you can't get the guide there, but you can get a wire down and your guide extension catheter can get down. And lastly, and I think this has been shown that with the Evolute frame, what I would recommend that you do is to remove the guide catheter over a wire. There have been a couple of cases where when you've taken the wire out and you've gone to remove the guide, that the guide gets a little bit stuck there. And there's been one case that was real difficult with that. And so I would recommend just take your final shot, bring your wire back, and remove the catheter like you see here. So Azim, maybe I'll pause there. Any other guides? I mean, you do a lot of these. Any other advice for the, not only the structural folks, but the interventional folks who aren't doing these about how to engage?
Yeah, so one of the things that I think is really important, especially when you have these patients with big aortas, is to make sure you're actually inside the core valve. It sounds crazy, but I've seen people struggling to cannulate and they were outside the valve all the time. So I always try and go with a pigtail first at times, or if I'm going my guide, if the wire will actually cross and go into the ventricle, I feel even better. And then I'll go with my guide almost into the ventricle and then come back up. That way I'm really sure I'm inside the core valve. I think the other thing also that's a good trick to remember, sometimes you just will struggle like crazy with the guide. And if you're not able to cannulate, take a diagnostic catheter. And I've done that too, is I'll cannulate with a diagnostic and then I'll put a 300 centimeter Grand Slam wire or something to then exchange to a guide. That can be really useful too. I think probably the two most important things I've learned are the ones you mentioned, which is always a half a size smaller, because you don't have the room to manipulate. And many times I have to admit, John, I've given up on trying to spend my time cannulating. I just try and wire blindly, from inside the valve, get a wire in.
Totally agree.
Yeah. Once the wire's in, I'll anchor that wire with a balloon or something to get a guide extension, because sometimes you can't actually get the guide in, but you get a guide extension in. The one I love is the one you mentioned, the last one, which everybody forgets about. Everybody's so happy when they do the PCI through a core valve that they were able to do it, and then they forget about it, right? And they pull out the wires to do their last shot, and then you pull on the guide and you can get really stuck into one of the diamonds, in the apex of the diamond. So it's really important what you showed about pushing your guide out first before you pull your wire. I think there was also a comment from Mark Manigas. Do you loop? Yeah, I think Mark, I just responded to that.
So again, this is just quickly to show sort of what Azim was talking about. So often that's about as close as you can get. Now, even if you get this close, I think you're in good shape. So here you can see a patient who's had an acute inferior wall. So it's about as close as you can get, but from there you should be able to get a wire down. And so here's a case where you could get a wire down. You didn't even actually need to get a guide extension down. This is a case where they did some aspiration thrombectomy. You can see with that catheter down there, often the guide will follow down there, and there's your case afterwards. So often, I think it's a nice case. You start with really not great support here, right? This is you're pretty far off field. You wire it, you're still there, but your catheter can often make its way down there, and that's why guide extensions can be quite nice. For the sake of time, I want to spend just the last couple of minutes here talking about the valve and valve concern. And so here's some photos from John Webb, but recognize that when you're doing a valve and valve, you're taking the old valve, you're pushing it up, and you're in essence creating a tube graft here. For the Sapien, it's a short tube graft. But if you have a patient who has a small root or has low coronaries or a high implant, this can be a concern. Often not, and I would say usually not, but don't think that it is always not. And certainly when we're talking about an Evolute or a core valve, and here's an Evolute and a core valve, you're making an even taller tube graft in those patients. And this is sort of what Azim was getting to about the fact that, you can be occluding the coronaries can be fairly not too challenging to doing a valve and valve with two Evolutes. And you can see what's going to happen here. You're going to create this tube graft, and it's going to extend up to above the coronaries there. So what can we do for this? One of the things that's come up is the basilica procedure. I'm not going to spend a tremendous amount of time because it can take people a long time. It's a lot to go into. But really what you're trying to do here is to create a laceration in the leaflet of the surgical valve that's there. So here's the surgical valve on the outside, and here's the leaflet that's been lacerated either with a sapien or with an evolute valve. And you can see by lacerating that and lacerating it where it is lying in front of the left main ostium, you then allow blood to flow down through the frame that wouldn't have been able to flow through the frame previously. So, you know, again, this is for the sake of time. What you do is you take two catheters, you put a gooseneck snare in, you wire through the valve leaflet, okay, snare it, you create your sort of flying V here, you electrify the wire and you pull up, creating this slit in it and hopefully helping yourself to be able to perform the procedure. I will tell you that while this can be challenging at times, certainly there have been some modifications to make this a little bit easier, but I also would not rest your laurels that you've gotten a perfect sort of slit right in front of the ostium of the coronaries. It is something that even after this, I've seen cases of coronary obstruction. So, you know, this is I think an imperfect procedure, but I think it's a procedure that gives you some chance where you otherwise would almost get certain coronary obstruction in a number of cases in patients who really can't have a redo surgery. Azim, I don't know if you have any thoughts about, let me add by this, there's been a lot of papers that have come out recently about CT modeling for coronary obstruction risk, both for native and for valve-in-valve procedures. We haven't started to do that yet, but I know a number of groups, both at Washington Hospital Center, some out in Seattle, Webb's group up in Canada, have come up with some different ideas about how to do this. I think it is something that we're going to be looking at more and more in the future. So let me just finish with just a handful of take-home points. So the first is that the decision of PCI pre-TAVR should be rational and pragmatic, driven by a dedicated heart team. Coronary obstruction during TAVR is rare, but be prepared. The risks include small sinus of Valsalva, low coronary heights, and especially valve-in-valve. Engaging the coronaries through the evolute frame requires modifications to your regular routine for coronary angiography. If the commissures of the native valve and TAVR are not inlined, this may require non-selective engagement, offshore wiring, use of guide extensions, and can be quite difficult. And lastly, valve-in-valve procedures increase the risk of coronary obstruction due to the creation of a stent graft, which also will make coronary re-engagement more difficult, if not impossible, when you're dealing with supraannular valves. And these, I think, are going to be important considerations when we're talking about younger patients in whom we may need multiple valve procedures in. So I think we're almost on time there, maybe a few minutes for questions. Thank you, Azim, very much for having me.
Thank you, John. That was really phenomenal. And thank you for allowing all the interaction. It made it lots of fun, especially around the cases. So I'm going to pass it on to the fellows. They have some questions, and there are probably some questions as well from the chat. So Sharon, if you want to either take a question from the chat or your own.
Yeah. So thank you for the talk. It was really interesting. I would like to ask if there are any predictors. I mean, once you finish to implant the valve, when you do a root shot, in the end, that predicts potential coronary, issues in the future. I mean, what are your thoughts about that?
So I would say that certainly you can see times where the native valve is pushed up against it. And Dr. Dowerman up north of us has sort of talks this white line sign where you can see the native leaflet that's pushed up and may predict sort of a later stent, a later coronary obstruction. But I do think it's an imperfect science. Early on with TAVRs, and even occasionally now, you have patients who, a week out or, a couple of weeks out suffer a sudden cardiac death, an out of hospital arrest. I suspect a handful of those are due to late or, sort of intermediate or late coronary obstruction. I don't know if there is a good way of predicting it after the valve, a great way of predicting it after the valve has gone in. You know, your root shot can show you some things. I think a lot of it is trying to understand it beforehand, and maybe some of this computer simulation, the CT simulation, will help us in that.
Yeah, I agree. I mean, we published a paper in JACC on delayed coronary obstruction, and trying to put all the delayed cases together. And I guess, we weren't able to predict really what the predictors were, where there were some features that were kind of more common. So self-expandable valves, it was more common with self-expandable valves having delayed coronary obstruction. So by delayed, it was the patient left the cath lab, right? So the patient had an aortogram, everybody said it was okay. Patient left the cath lab, either a day later, 4 days later, even sometimes a week later, the patient has a coronary obstruction. And there, one of the main variables was self-expandable valves. I think also the leaflet, something we don't know enough about. So the sinuses of Valsalva width and the leaflet length. I don't measure much leaflet length, John, except when I have a case where I'm worried about coronary obstruction. Then I start measuring how long the leaflets are, because I'm trying to predict where it's going to go, that leaflet, when I push it upwards, right? But I think there's still so much we have to learn. Anyway, please carry on.
Yeah, an interesting question from the chat. During a STEMI, if a case is if you're trying and trying, would you opt for a lysis, fibrinolysis? What are you?
Yeah, I mean, I think if certain, right, so thrombolytic therapy is a pretty good therapy for a large STEMI. Obviously not as good as opening up the artery and putting in a stent, but it works well. It's still used in the United States. If you have tried and have been unsuccessful, I think that if there's not a contraindication, and I don't think having access to the radial or the femoral is a contraindication for it, and you can't do anything else, I think lytic therapy would be a reasonable alternative. If you say I'm not going to be successful in that, then to try lytics, yes.
Yeah. But I would only make that decision after I've tried to do a coronary angiogram or done an aortogram, because if it's a mechanical obstruction by the leaflet, okay,
right.
Thrombolytics are not going to help. It has to be a classical STEMI, like the one Dr. Forrest showed.
Yeah, right. And again, this is going to be like that case that we had last week that was 3.5 years out, came in with an inferior wall MI, right? So those usually, but not all the time, are going to be, you do an aortogram, you'll see flow going down, and you'll see your mid RCA is just stumped. So right,
John,
before
I go to Theo, because Theo's on, he hasn't made a comment yet. I wanted to say we haven't had any STEMIs or ACSs like the ones you have, but Joseph Rodas-Cabot is putting together a multi-center study and is looking for them. Okay. So please reach out to him, because you could maybe contribute with some of your cases. Okay. Theo, did you have a comment?
Yeah. My comment was about the role of FFR or IFR in evaluating, the stenosis pre-TAVR, meaning like whether or not you should base your decision regards the revascularization based on the IFR or FFR. And if so, do you use FFR? Because there's some concerns about the hyperemic response on adenosine might be tampered because of the severe aortic stenosis. So how do you approach the role of FFR or IFR in these patients?
So it's a great question. So in preparation for this talk, I reviewed a whole bunch of stuff in the last handful of weeks, and there's more and more that's coming out about IFR and FFR in the setting of aortic stenosis. We've tended to use it, in these patients. But that more is if there's sort of large LAD, proximal RCA disease. I believe, and correct me if I'm wrong here, I think that what it said is that FFR and IFR may not be as predictive as it is when you don't have severe aortic stenosis. And so I think the data is coming out there. I think it's tough, right? So I mean, you can use IVUS, but IVUS of besides the left main, there's not a great deal of data around luminal diameters, et cetera. So we still do use it, although there certainly are changes with hyperemia, et cetera, that are not necessarily accounted for when you're dealing with patients with severe aortic stenosis.
Yeah, some people, they say that the IFR might be better in these cases because it's the wave free, the systolic period compared to FFR. They're more heterogeneous. When they check the FFR pre and post TAVR, there are more changes, significant changes. So, but also the IFR is some studies have said that might not be the best as well. There's a lot of variability.
We've been doing both of them. So we've been doing, we'll do the IFR first. It's nice and easy, and then you can just switch over to your FFR. But so, yeah.
Okay.
Do you want to grab this question?
Yep. Maybe the last question from the chat. Which axis do you prefer when you try to engage a TAVR?
I'll say that we've now started using the radial a fair amount if it's not at the time of the TAVR. So for those cases that I talked about here, we went radial for those and didn't have a significant amount of difficulty. I do think that, right, if you have this does require a fair amount of manipulation of your guides, and it's nice to have as close to sort of a one-to-one responsiveness as possible. So if you have a really tortuous right subclavian or a nominate where it's making loops, we know that can be pretty hard to manipulate that catheter. And so in cases like that, it may be easier to go radially. If it's a nice straight one, you're going to be fine. I think in the setting of a STEMI and a patient who's in shock or other things, I still have a tendency to go femoral to get it in there quick, thinking that he or she may need a little bit of hemodynamic support as well. But in the cases I've done, elective ones, stable angina, years after their TAVR, I'll go radial. And it's the vast majority of the time it's successful. And the times it's not, it's more because of the significant tortuosity just makes sort of the one-to-one torque difficult.
Yeah, absolutely. Shouldn't any final comments, and then we'll close up.
That was a great talk. Thank you so much.
Okay, great. John, fabulous talk. Thank you so much. We all learned tons. It's really good seeing you. Look forward to seeing you in person, mate. Okay.
Absolutely.
Take care.
Stay safe, everyone, and happy early Thanksgiving.
Yeah, you too. Thanks, John.